and welcome to our TSF's New England Patient Day for NMOSD and MOGAD. Thank you for coming in on a Saturday. It's chilly, it's a little gray, but we're gonna make today really bright, special, and inspiring and whatnot. So my name is Samira. I am a patient living with seronegative neuromyelitis optica spectrum disorder. I'm also the founder and executive director of the Samira Foundation. I started this organization 2 months after getting diagnosed myself, kind of out of desperation and loneliness and fear that I would die from this just because nobody knew about it or because we weren't doing enough as a community. So maybe it was this fight or flight mode that I had in me, but within 2 months I said, I gotta do something. I don't know what I'm gonna do, but I gotta do something. And 10 years later, we are here. We're now a global nonprofit organization dedicated to raising awareness of NMOSD, MOGAD, and other rare neuroimmune conditions. We're very passionate about community development and engagement like today. We support research and we advocate on behalf of patients. I am really proud and love to say that we're truly a patient-led, patient-powered, science-driven, therapy-agnostic organization. Diversity for us is considered a superpower. We have 70 ambassadors who are patients, caregivers, clinicians, and researchers from 28 countries representing the foundation. Our website is available in 24 languages. We have webinars available in 12 languages, support group meetings running in 11 countries. And, just look at us up here. We're, so different, but came together for a cause that really means so much to us. I'm going to keep the intro short because we've got a very exciting program planned for all of you today. But first, I want to start with, raise your hand if this is the first time that you are meeting another patient in real life. Okay. Oh. That's a really significant moment in your diagnosis journey and very powerful. I will never forget the first time I met another patient. It was really a turning point in my sort of journey with NMOSD. So I want to talk to you about why today is really, really wonderful. And I'll start with the personal stuff. So first and foremost, I live in the building next door. So it's almost like having everyone home to my house and in my neighborhood. Like, welcome to where I live. Marion also lives here. We never leave because we don't have to. So having all of you come here and enjoy and, be where our home is really special. But, after taking our sort of show on the road, since 2022, we've been in Milwaukee, we've done this in Dallas, LA, New York City, Verona, Italy, Paris, France, and now Boston. It's so special because Boston holds a very significant place in my heart. I moved here 17 years ago for university, and this city has given me an education. It nursed me back to health during my sickest of days. This is, where the genesis of the foundation happened, and so many people in Boston, like these two guys, helped me and the foundation get to where we are. And it's, my friend made all of the centerpieces, for example. This is something I can't do in other cities. I used to work in this building, in fact, and yeah, it's just really nice to be home and do this for our home community. So really, thank you so much for coming and making the time to be here. I know that sometimes these educational events can be intimidating, they can be scary. Sometimes you find out things that are not necessarily pleasant. But today really, really is about you. And I want everyone to leave today feeling more informed, more aware, more connected, empowered, inspired, and really leave today being like, you know what? I got this, but I'm gonna be okay. I'm gonna be okay. I'm not alone, clearly. There's so many people invested in making these diseases more known, more researched, and just have a better future for us. So really take advantage of today. Ask questions, make friends, take notes. There is no such thing as a stupid question at all, at all, at all. The other significant thing about Boston is Michael Levy is here, which we're very lucky about, and so is Marcelo Matiello and Tanuja Chitnis and a bunch of other doctors in Boston. So we're very lucky to have such a great group of experts here in Boston. Yeah. So we've got a really special day planned. As you can see, our agenda is packed, but we've built in breaks. However, if you need to take a break beyond those breaks, please feel free to excuse yourself. The restrooms are somewhere over there. You could take a breather, get coffee, get water. We have a nice lunch planned. So just be comfortable and yourself. Today would not be possible without our sponsor, so a very, very special thank you to Amgen. They are our platinum sponsor. Raise your hand if you're from Amgen. Yes, thank you, Amgen. As well as UCB. I think I see the UCB crew over there. Thank you so much. We also have Alexion back in the room over there, and Portal Instruments. And a very special thank you to Eversource Energy on behalf of our wonderful ambassador, Marion Jones, who you will see a lot of today. They've made a very generous donation, so we're super grateful. But also thank you to the TSF team. We have Michael Devlin here. Raise your hand so everyone can see you. You've met Jill, our chief of staff. She'll probably be running around like a crazy woman today, but she's wonderful. We have Nikki, and we have our ambassadors, Marion, Terry, Karen, Jerome, and of course, we have a special guest today, Christine Ha. She is probably the most famous NMOSD patient. She's also a celebrity chef. She won Master Chef Season 3. She was the first blind contestant. So we're really proud of her as a community and really excited that she'll be here today. And before I let these two guys say something, happy NMO Awareness Month. So if you didn't know, March is NMO Awareness Month, and April is MOGAD Awareness Month. So we'll be celebrating back to back. Follow us on social and whatnot. You can see all the different ways in which you can get involved. And tonight at 10 o'clock, for the third year in a row, Niagara Falls on the US and Canadian front will be lit up pink for the foundation today. So that's really exciting. Thank you. And maybe just a few words from Dr. Levy, who is the chair of our Medical Advisory Board.
Just to say thank you, everyone, for coming. I'm Michael Levy. I've been taking care of patients with NMO since 2006 as a resident. I met Marcelo sometime around then. We were both fellows working hard, trying to understand this disease. He was at Mayo, I was at Johns Hopkins, and then Marcelo moved up here, and I followed him. And we'll continue to work with him and with all the great team here. So looking forward to the events today. Thanks.
Yes, thank you. And Marcelo?
Well, thank you, Sumaira. Thank you, Michael Levy. Thank you for coming. I know it's a very special moment for Sumaira, but also for us. This picture where I'm talking was a patient day, a New England patient day. Dr. Chitnis, Dr. Levy, and I organized this a number of years ago, and Sumaira came with a little table with some pink bands. And now she is this leader in the field of patient advocacy, the leader in the field of optimism, and even in the field of sponsoring research, sponsoring medical education. Many of us in this room, in the medical field, have to thank you for your support for our research, but also for the support you give to all of our patients. Every time, indeed, every time we need to bring optimism to the patient, say, well, visit the Sumaira Foundation website. All my patients know, I'm sure all of them, of other colleagues here know that as well. And just a brief story, I invited Sumaira this morning to go get breakfast, right, in preparation for this. And she said, dude, are you crazy? My makeup and hairstylist starts at 8. So, but I have to tell you that I had to postpone my 6-year-old daughter's birthday, which was scheduled for today, the party, to tomorrow, so I could be here. But I do need to buy the piñata tonight, so I'm sure we'll stay on time. Thank you, Sumaira.
My pleasure. Give a round of applause for these two. They're fabulous. All right, so let's get the show started. So why don't we have a seat? And I'm also going to invite up Dr. Tanuja Chitnis, who is joining us from the Brigham and Women's Hospital, and Dr. Hamza Coban, who is joining us from UConn Health. Please join us. Okay, so why don't we start with introductions? I've already said who I am, but maybe Hamza, Dr. Coban, you can share who you are.
My name is Hamza. I'm an MS neurologist and neuroimmunologist, and I also take care of patients with neuromyelitis optica spectrum disorders as well as MOGAD. I'm based at UConn in Farmington, Connecticut, UConn Health Center.
Thank you. And Dr. Chitnis?
Tanuja Chitnis. I direct the Pediatric Multiple Sclerosis and Neuromyelitis Center at the Massachusetts General Hospital, and I also co-direct the Brigham Multiple Sclerosis Center, where we see a number of patients with MOGAD, NMOSD, and other autoimmune diseases.
Dr. Matiello?
Hi, everybody. I'm Marcelo Matiello. I'm the Vice Chair of Clinical Affairs at Mass General Hospital, and I serve as a co-director or associate director of Michael's Levy effort in the NMO and MOGAD unit.
Dr. Levy?
Can I take a moment to introduce my team?
Absolutely.
Right down here, best study coordinators and physician. There's Becca, Gabriella, Becky, Melanie, and Aisha.
Welcome. Thanks for being here. So we like to start our patient days with this particular panel because I know how much of a privilege it is to even have access to these folks today. So I have some questions for them and they'll answer them, but we are gonna have a dedicated time for Q&A. So definitely don't be shy, ask these doctors questions and get all of your questions answered today. So let's start with some basics. I would like to hear, let's start with you, Marcelo. Can you please share the 2024 definition of NMOSD and some common symptoms?
Well, thanks for the question. And NMO is a condition that in which patients living with it have a what's so-called immune response or too strong of an immune attack to a specific protein, or most of the patients do harbor this antibody that targets a protein in the brain called aquaporin 4. Patients usually present with inflammation of areas of the brain or the spinal cord which are rich in this protein. So the condition has a predilection, has a preference to cause inflammation of the optic nerves, of the spinal cord, and other places in the brain, which also harbors a lot of this protein aquaporin 4. It's a condition which presents within hours to days. So if someone is presenting with optic neuritis, they may develop blurred vision that increases within hours or within the day, in causing blurred vision or pain on the eye movements, or if the inflammation is in the spinal cord, it causes weakness, sensory changes, or bowel bladder problems. It's a condition that we can make a diagnosis even with one presentation if the antibody test is positive in the blood. And this antibody is well known to most of neurologists in the country, but what it means and how to tackle the information is still information that neuroimmunologists or doctors who are dealing with an immune response to the nervous system has a little more tools to diagnose and treat. So in summary, the 2024 definition of NMO is a condition of autoimmunity or the patient's own immune system attacking a protein and causing damage, but also a disease that is treatable, a disease that is preventable, in a condition that people can help each other.
Great, thank you. Dr. Levy, can you provide us with the 2024 definition of MOGAD and common symptoms of the disease?
Okay, so MOGAD is a newly recognized condition, but it's been around for a long time. and it's overlapped with NMO and MS, but only recently has emerged as its own thing. And it's its own thing now because we have a good blood test for it since 2015 in the UK, 2017 here in the US. And it looks a lot like both conditions. They get optic neuritis a lot, sometimes transverse myelitis, and kids get brain lesions causing seizures and things like that. But the blood test can distinguish these patients from aquaporin 4 NMO, from MS, and from other conditions. And it also helps us know which treatments to use in the future to prevent attacks. And we also have a sense that MOG lesions tend to heal better than aquaporin 4 lesions. So it could give you a little bit more information about what your future looks like during the healing process. So that there are definitions. They're clinically based and lab-based, so it's how you present to the doctor and what blood test you test positive for, and then it's incumbent on us to sort it out, make sure that it's not something else, because these diseases all look alike. Sometimes it takes a little bit of expertise and digging to actually make the correct diagnosis.
Thank you. Dr. Hamza, can you speak to the prevalence of these diseases both in the US and worldwide? I've heard a lot of numbers over the years, and I'd like to know the most current numbers.
Thank you for the question. For these conditions, thankfully, in a way, they're still rare, especially MOGAD and aquaporin 4 positive NMO. But there's a smaller fraction of this patient population is double negative, seronegative, and NMOSD. The numbers, the incidence and prevalence numbers can vary from region to region, from country to country. Probably the better numbers are coming from maybe to some extent United States and Europe, maybe in Asia, Japan as well. For NMO, aquaporin 4 NMO, it ranges from 1 to 10 in 100,000, maybe a little more, depending on the study, depending on the time it was done. This is for adults. For children, it's much rarer, thankfully. NMO and for aquaporin 4 positive NMO, it's much rarer. But MOGAD is a little slightly more common in children than adults. And among children, probably among acquired demyelinating disorders such as MS, NMO, and MOGAD, probably MOGAD is slightly on the higher in number. But the estimation and the prevalence still probably a little vague because we don't have great data. Again, it would range somewhere from 5 to 15 over 100,000. The other aspect of epidemiology, there are some sex differences, predominance, especially in aquaporin 4 positive NMO. There is a profound female predominance in aquaporin 4 positive NMO. It's up to 8-to-1 or 9-to-1 female to male ratio. This is true for pediatric patients too, still female predominant. But for MOGAD, it doesn't look like there's a significant difference between different sexes. It's close to 1-to-1 for the most part. The other part would be if any genetic or ancestry specific risks or different prevalences. For MOGAD, I don't think there is a significant difference between different races or ethnic or genetic background. But for NMO, aquaporin 4 positive NMO especially, it seems to be slightly more common in Asian and South Asian populations. Also, maybe relatively speaking, slightly more common in African ancestry.
Great, thank you. Dr. Chitnis, I'm really happy you're here today and to bring this pediatric perspective for sure. And just kind of piggybacking off of the question for Dr. Coban, can you speak to how these diseases manifest for children, both in NMOSD and MOGAD? How does that differ from the adult experience? And then another question for you, can you also talk to us a little bit about monophasic versus non-monophasic aspects of these diseases?
Yes, so first of all, thank you, Samira. This is just a wonderful symposium, and thank you for the invitation. So around the manifestation of these diseases, MOGAD and NMOSD in children, maybe I'll first speak about MOGAD. So MOGAD is actually more common in children when you look at the frequency and percentage-wise than in adults. So compared to my pediatric clinic and my adult clinic, in my pediatric clinic, about a third of the children that I see with any sort of demyelinating disease, including optic neuritis, transverse myelitis, brain lesions, about a third of them will have MOG antibodies. And although my pediatric clinic is much smaller, and I don't have, thousands of patients, but it is small, but still it's about a third have MOG. In my adult clinic, about 5% of my patients with any of these conditions presenting symptoms have MOGAD. And so that is played out across the globe, and many studies have really shown this, that MOGAD tends to be a more pediatric predominant disease when you look at percentage-wise. When you look at just frequency-wise, adults are more common since there's a longer lifespan, but they sort of even out. So it is a very common pediatric disease. In terms of presentation in children, so MOGAD presents a little differently in children. Very young children tend to have something called acute disseminated encephalomyelitis, which means they can present with brain lesions, seizures, oftentimes just very fulminant, very severe presentations. Oftentimes, they need to be admitted to the hospital right away. They might have weakness, bowel bladder problems, optic neuritis, many, many symptoms. So it's quite severe at first presentation in very young children. And I'm talking around the ages of anywhere from 3 to 7. That's the most common. When children are a little bit older, and my young teenagers, so my 10, 11, 12, 13-year-olds, they tend to present with optic neuritis. And it tends to often occur in both eyes. We call it bilateral. Sometimes it's one eye, but usually there's some involvement of both eyes. So optic neuritis in teenagers. And then in even older teenagers, especially 17, 18-year-olds, they tend to present with transverse myelitis involving the spinal cord. And then in my young adults, they tend to have optic neuritis and transverse myelitis. So these rules are not absolute, and there's lots of exceptions to that rule. So you might have an older teenager presenting with this acute disseminated encephalomyelitis presentation, a younger child with optic neuritis, but those are in general the different presentations for MOGAD. And then in the adult population, it's more like an NMOSD, optic neuritis, and transverse myelitis, and some brain lesions in my MOGAD population. For NMOSD, the clinical presentation for kids who have aquaporin-4 antibodies is very similar to adults. It's a very rare disease in children, but we do have some children with NMOSD with pediatric onset. And it tends to present with optic neuritis, with transverse myelitis like adults. Sometimes there is more brain involvement, again, this ADEM presentation in very young children. And I think that hopefully answers questions around presentation.
Yes, very good, very thorough and comprehensive and easy to understand. Okay, I'm not going to choose a person to answer. You guys can decide who's going to answer. But in the Facebook groups, I have seen a lot of questions, maybe assumptions and ideas about folks having MS and NMOSD or MOGAD. So can you have both? Can someone debunk this myth? Anyone?
I think I can start. I'm sure everyone will pitch in. In my opinion, I think it's, let's break it down to MS plus NMO. I think it would be extremely unlikely to have both, especially for with a Coban-4 positive NMO. The antibody testing is highly specific, and if in the right clinical setting, if they have the the typical presentation with optic neuritis and typical type of optic neuritis and inflammation of the spine, it's going to be neuromyelitis optica. For MS, we use very quite sophisticated. It's going to be more sophisticated soon enough. Certain diagnostic criteria, even though we don't have a specific test, based on that diagnostic criteria, it's highly unlikely to be an NMO patient get diagnosed with MS in the absence of antibody. For MOG disease, MOGAD and MS, I think that the first thing to think about it's true, all these three conditions share a lot of features. First thing to make sure about the antibody, because a lot of times we know from the historical data, some MS patients tested positive for MOG antibody. Some of them turned out to be MOG disease rather than MS, but some remained as MS, but false positive MOG disease, especially in low antibody titers. Unfortunately, there's one challenge we have to deal with in MOG disease. The type of test being done and where it's done sometimes, and also that the titer can make a difference. So for a true positive test, we accept, in general, a cell-based assay and higher titer, maybe ideally 1 to 1,100, maybe.
Yeah, we definitely agree that these are different conditions, and that the fact that we have a antibody test helps differentiate them, but sometimes the presentation could be similar, even though in NMO, the presentation is usually more intense. But in MOGAD, we even have a study in which about 10% of the patients on a large series of MOGAD patients had very typical MS findings. Of course, when we look into the levels of the antibodies, when we look into how the patients did year after year, then we find a lot of those really have more of the characteristics of MOGAD, but still lives a few that we have a very hard time sorting it out. It's a small percentage, so most people we will be able to differentiate quite well.
Great. Dr. Levy, walk us through the steps to a diagnosis, starting with telltale signs, labs, imaging, LPs, criteria, all that. 2 minutes.
So first you come into the hospital because you woke up and couldn't see, or there's a gray spot in your vision, or maybe you swung out of bed and your legs weren't working, and your loved one called the ambulance, they bring you in. First thing that happens is the emergency room doctors and the neurologists will examine you and see what's going on. And if the problem seems to be something that's happening in the spinal cord, brain, or optic nerve, you're probably gonna get an MRI fairly quickly. Everyone here has a story about how quickly that happens, but it should be quick. And then if we see a lesion there, we're gonna start looking at the pattern of the MRI and see if it makes sense that it's more MS or NMO or MOG. We're gonna send all of those tests, they're all blood tests, and then maybe do a lumbar puncture to look for some findings that are more specific for MS. All of these take 10 days. So you're gonna be in the hospital while all this stuff gets sent out. In the meantime, we're gonna be treating inflammation from, it doesn't matter what, whether it's MS, MOG, or NMO, you're gonna get treated to suppress the inflammation. And then when you come back to the clinic, we'll be armed with the data. Then we'll say, okay, this is what everything looked like. This is how we're putting all the clues together. We may try to get a few more clues, maybe an eye scan or something like that, just to get a little bit more information if we're not sure. But usually I think we'll have a better sense of what happened when you come back into the clinic, and then we can plan to prevent anything from happening again in the future.
That was perfect. Thank you. Dr. Chitnis, can you educate our audience in the most layperson's terms as possible about the aquaporin 4 antibody, the MOGAD antibody, and then what about the rest of us in La La Land as seronegative?
Yes, so I got the easy question.
I'm giving you all the hard ones because I know you can handle it.
So what we know about these antibodies. So antibodies are one part of your immune system, and I kind of think of your immune system as a three-part stool with three parts of the legs. You have your T cells, you have your B cells that produce antibodies, and then you have your monocytes. So the B cells that produce antibodies can produce antibodies to viruses, to bacteria, to things that you see in your, in your body. Sometimes they form antibodies to parts of your body, to proteins that are within your cells. Why that occurs is the billion-dollar question, and that's part of figuring out tolerance. So usually those cells, B cells that produce antibodies to your own proteins, get eliminated. But for some reason in people with autoimmune diseases, often they don't get eliminated. Okay, so what is aquaporin 4 and what are the antibodies to aquaporin 4? So aquaporin 4 is a water channel that's present largely on a cell called astrocytes, which are within the brain. They're kind of supporting cells. They support the structures in your brain. They surround the lining of the brain, and these cells are quite common. And aquaporin 4 is the target of one of these antibodies. Why does your body cross-react and produce antibodies to this aquaporin 4 is unknown. Aquaporin 4 also lives in other areas of the body, including the kidneys and other things. So that's aquaporin 4. MOG is another protein in your brain, and it's present on the myelin sheath or the myelin coating of your brain cells. Now, when I think about brain cells, I think about nerves, which are like your electrical wires, and then there's a rubber insulation around the electrical wire, and that's the myelin sheath. That's produced by a cell called oligodendrocytes, and that myelin contains lots of different proteins, including the MOG protein. Again, your body produces, in some cases, antibodies to this MOG protein, and that's the million-dollar question: why does it do that, and why does it lose tolerance?
What about seronegative?
And seronegative. So, the larger community has discovered antibodies to MOG and aquaporin 4, but of course there are people who don't have these antibodies. One thing I will add is that sometimes we have to test and retest for antibodies, and sometimes they become positive with time, and that's one thing. But, Samira, you might have been tested many, many times for antibodies, and no one found antibodies. So there may be antibodies that are that have been not discovered because there are proteins that have been hidden, or it's just very difficult to discover antibodies in some cases, or there are different types of cells that are causing the autoimmunity in some cases. And that might be happening with seronegative NMOSD and other seronegative diseases.
Great. So, did you want to say something? Oh.
Not really, but I can add for especially seronegative and NMOSD. I think we all agree that we need to think harder before calling it seronegative NMOSD and making sure we're not missing any other diagnoses. This could be MS. This could be another autoimmune disorder. In fact, there are so many things that could give similar spinal cord lesions that can look like an NMO, including vascular problems, some kind of vascular insufficiency or fistula, even with trauma sometimes. There are other autoimmune conditions such as sarcoidosis can look like NMO. So overall, we need to think harder before calling it seronegative NMOSD.
Thank you. Okay, let's shift gears to treatments. Just a little backstory, and many of you can relate to this. 10 years ago, when I was diagnosed with NMO, I was told a few things. The prognosis isn't great. Don't Google the disease because everything on the internet says you'll be dead within 5 years. There was no FDA-approved therapy. There was one treatment that works, but sometimes it doesn't. And we're just going to hope for the best. Now, fast forward, 2024, we have almost 4 FDA-approved therapies that are highly efficacious. So this, I think, deserves a round of applause. I mean, we have come so far with treatments, which is a blessing that rare disease patients, I know we all feel this relief that, okay, there's something that works for me that was designed for me. So just a special nod to our therapy partners who are in the audience. For many of you guys, it's a job, right? But your job and what you're contributing to has really drastically changed the landscape of NMOSD. So thank you for all what you're doing. And as far as MOGAD is concerned, we've had several clinical trials happening, and I'm certain, as well as these folks up here, that within the next few years, there probably will be an FDA-approved therapy for MOGAD. So really exciting times ahead for treatment. But very quickly, Marcelo, can you talk to us about acute versus long-term treatment in 2 minutes?
Okay. Oh, don't start the clock yet, right? Give me a little extra time. So in NMO and MOGAD, the acute treatment should begin as soon as possible. And in both conditions, it starts with efforts to reduce or stop inflammation. Most commonly, it's high-dose steroids, and most of you know it's IV 1 gram of medication called Solumadra or methylprednisolone. The medication is done anywhere from 3 to 5 days, and if we have good results, then we start planning the prevention step. So we are done with the acute phase. However, if the results are not there, we escalate treatment to most commonly plasmapheresis or plasma exchange. Is a procedure which removes plasma or removes the liquid part of the blood and then discard that part, so discard the antibodies, the other inflammatory substances, and then return the cells of the blood with a solution of albumin and fluids, right, physiologic saline. So that's the acute treatment. Sometimes when plasmapheresis is not available, we use IVIG also as a acute or as Michael Levy always says, putting the fire down or getting rid of the fire. Very soon, in most patients, we want to start the second phase rather quickly as well, which is now the prevention. And if you see his presentation, he now shows the smoke alarm or things that really prevent a recurrence or prevents another attack of NMO or MOGAD. As you mentioned, in NMO, there are 3 FDA approved. One is inebilizumab, sartolizumab, and eculizumab, and hopefully another complement inhibitor will be approved soon, razalizumab. And I think the details of how they work and how each patient fits a little beyond the 2 minutes you gave me, but they are wonderful, wonderful options. They all have been trialed, at least in 2 clinical trials, well-designed in the US and worldwide. As you mentioned, in MOGAD, we have looked into our experience with all our patients, and we think that at least 3 options work really well: IVIG, rituximab or other B-cell inhibitors, and a tablet called mycophenolate mofetil. There are pros and cons of each of these options, and as you mentioned, there are great other medicines being trialed, and hopefully, as you mentioned, in a year or 2, we have some good results.
Amazing. I think we need to celebrate all of the advances that we've made in our community. And thanks to people like all of you on the stage, our therapy partners, you guys as patients contributing to clinical trials, donating blood, this truly is a team effort. We made it as far as we did because every single one of us played a role in it. And I think it's just incredible where we are today. So really, I'm so happy. So I've got 2 R words in my life that are triggers. Michael knows that one of them is relax. Don't tell a woman to relax. It's never going to get you anyplace good. But the other R word is relapse. Ugh, it's just the bane of my existence. Dr. Levy, in 2 minutes, can you tell us about, because I want to make sure you guys have time to ask questions too, but talk to us about relapses and what is a pseudo-relapse, AKA, Marcelo, you taught me this word, another R word, recrudescence.
Okay, so a relapse is when your NMO or your MOG or your seronegative disease attacks again. An attack occurs when the immune system invades the nervous system. And for the most part, it tends to be random where it attacks, mostly in the optic nerves and spinal cord, but randomly in those areas. So if you've already had an optic neuritis in your right eye, then the next optic neuritis could equally be in your right or left eye. It just seems to be random at that point. But if your symptoms come on exactly the same as before, then sometimes I think, well, maybe it's just the old damage that's causing your symptoms this time. And that's what a pseudo-relapse is. And that could happen if you have a urinary tract infection or pneumonia, or even if your body temperature is increased from exercise on a hot day, those symptoms could come back. That's called recrudescence. And then if you cool down or you treat the infection, that can go away. Now, if it's a real relapse, then cooling down and antibiotics won't help. Then you need the acute treatment again. We'd like to see that on an MRI because if it's the same as previous, it's hard to tell. Is it a recrudescence? Is it a real relapse? That's where an MRI is really useful. But if I have a MOG patient, they've only had optic neuritis in the left, and then they call me and they say, I can't see out of my right eye, obviously that's not a pseudo-relapse. That can't happen. There was no damage there before. So that's probably a relapse. So it's all these clues you put together, and we love MRI. MRI gives us an insight into the actual tissue, and we love getting them because it can really give us a lot of clues.
Excellent, and very on time. I have a final question, and then I would love to open the floor so that you guys have the chance to ask these wonderful people questions as well. You've all been in the field for quite some time now. I'm not going to age you, but it's been a while. And you've seen the evolution of these diseases at its worst, and now kind of where we are now is at its best. And must be so rewarding to see the fruits of your labor, contributions that you've made, that your labs have made, to see all of these scientific advancements. So I'd love to hear from each of you briefly. What are you looking forward to? What excites you about this field? We'll start with you.
Yeah, okay, I can start. I can be the youngest here, probably, but
Actually, me probably.
I'm sure. Yeah. For me, what I've learned from textbooks or on the lectures, and what we know about NMOSD and MOGAD now, there's a tremendous difference, especially in terms of having these quite specific and also quite sensitive antibodies, and making these distinction whether NMO, MOGAD, or MS, because most of these patients labeled as MS and treated as MS, and some of those patients didn't react well to typical MS medications. It's fascinating to see how things evolved over short period of time, really, over the past maybe 10 years, maybe a little longer. But for the future also, there's a lot coming in the pipeline in terms of therapeutics, and also other aspects of these disorders, not just treating the disease, but also treating the patient and treating the symptoms, hopefully leaning more towards those areas, and seeing more breakthroughs and better treatment options for symptomatic treatments too.
Great. Dr. Chitnis?
So I'm looking for the ultimate cure. I think that this is hopefully going to be in our near future. We've made a lot of advances with treatments that can control these diseases, that can suppress the immune system in very positive ways. But I think we are all looking for that treatment that's going to get rid of those cells, those B cells, those T cells that are actually causing NMO, MOG, seronegative disease, and either inducing pure tolerance, getting rid of those cells once and for all, and hopefully just stopping these diseases.
Yes, yes. Dr. Matiello?
Of course, second to my colleagues here, the cure is where we want to be. We all have other things to do, right? We have the lives to live, and even though under treatment it looks quite like a cure, of course, it's still with medications and doctor's visits, but hopefully in the future that's obtainable. What excites me in the near future is how do we provide access beyond what we have here in Boston or large cities in the United States. How other doctors know about this, how they use correctly the tests and the medications. And even in a broader sense, how other countries benefit from the work that is done here, and how do we benefit from the work that is done there. With that, I want to give a shout out to our NMO MOGAD MS nurse, Karen Wintington. Karen.
Hi.
And to say that it's much, much beyond just the physicians or the pharmaceuticals. It's really taking care of these conditions do require the help of experts in other fields as well.
And last but certainly not least, Dr. Levy, what excites you about the future?
I am equally excited with what Dr. Chitnis was saying, and I think you should all be too, because you guys have a disease that is scientifically very, very interesting to companies and to scientists out there, because we know exactly what your immune system is targeting. And in the future, we won't have to suppress your whole immune system. We could just re-educate it so that it doesn't attack that one thing. And because you have a known target, we can just hopefully in the future, as Dr. Chitnis was saying, just switch it off. So you're going to be a model for other autoimmune diseases in the future. But I think NMO and MOG have the potential to be among the first for this kind of therapy.
Love that. Great. Okay, it's now time for Q&A. So Jill, how does this work? If anyone has a question, you're going to bring the mic to them? Yep. Does anyone have a question? And if you want to ask any specific doctor a question, you are most certainly allowed to do that. So anyone, don't be shy. And if you don't have questions, that means I did a really good job. So I'll take that too.
Looks like we have an over here.
Go ahead. Yep. And if you could introduce yourself, your role, the disease you were impacted by, that'd be great.
All right, my name's Kevin Sennett. I'm here with my wife Colleen, who's a MOGAD patient. And we were here the day you had the little ping table set up here with the bracelets.
know.
And that patient day way long ago. Yeah, I mean, we've been living with this for a long time. And I think for people who are newer, the question I would ask is, when you're having these symptoms, right? What would you tell them how quickly you want to be able to react to this? If you're having a relapse versus if you're having a first-time attack, is there a sort of a timeline that kind of helps minimize the damage?
So I can start with a response to that. I think with any attack, and I tell anyone, all of my patients, if you think you're having an attack, contact your doctor right away. And even though it might be a recrudescence or a pseudo-relapse, it's better just to contact your doctor and talk through it and say, do I need treatment? Do I need to come in? Is this something that could be an attack? It's better to treat attacks sooner rather than later. So, hopefully within 1 to 2 days, getting either into the clinic, to the hospital, emergency room, that's very important. And we know that starting treatment earlier, especially if it's a severe attack, does help in the longer term. Fortunately, with MOGAD, there's pretty good recovery after attacks, but we don't want to let things go too long. And especially if it's a more severe attack, there is emerging data in all of these diseases that secondary treatments like plasmapheresis are helpful if they're started earlier rather than later.
Anyone else? Yes, we have someone in the back over there.
So a little bit piggybacking on the question. My name is Andras Troje. I had my first MOGAD attack about 4 months ago. I'm still on prednisone, which is why I'm, with the mask and everything. And, as I'm kind of preparing for going back to normal, regular life, I'm a scientist. I travel a lot, in other countries. So one of the questions that I have is, if I go abroad and I have an attack in a country where maybe, I go to the emergency room right away, but I do have this fear that the doctors won't know what it is, or, they don't believe me, or, that I will not be able to get the, treatment for the acute phase of the disease right away. So what would be kind of your advice on how to deal with those situations where maybe you go and they just, 3 days, nothing is happening in the hospital and you're not moving along? Thank you.
Andra, thanks for the question. And it's largely depends where in the world you are. Many large centers in Europe and Asia and Africa, they are even collaborators with us. So a lot of times going to the Sumaira website, or you can identify places that have that type of knowledge, and also leveraging technology, right? So if your physician is here in Boston, they can communicate with a colleague, with the physician overseas to provide expertise. Steroids are available worldwide. Possibly plasma exchange and IVIG may not. So, but the good news is that when people are under treatment for prevention, the risk of a relapse is very low. And even when relapses happen, the severity, the type of symptoms are much, much more mild if people are under treatment.
Great. We have time for one more question, but I also just wanted to say these doctors will hopefully be with us for most of the day. You can ask them questions during the break and the lunch, but yeah, there will be plenty of opportunities to talk to them. But one more question. I think Mark, no, sorry, right here.
Thanks, I appreciate it. Hi, my name is Tom Goss. My daughter Isabella was diagnosed with MOGAD in November. First, we're very grateful for the great healthcare we had access to here, right? We got into an ophthalmologist the day of the first symptoms, got into Mass Eye and Ear overnight, admitted to Dr. Matiello's service in Mass General, and treated promptly. We're fighting a battle royale with our health insurance to get coverage for treatment of MOGAD because they clearly don't understand what the differences between evidence required for approval of a treatment for a rare disease versus a standard disease exist. So I'm a pharmacist by training, and I've worked in healthcare for 35 years. I actually have worked in the rare disease space professionally for a number of years, and now I'm seeing it from a completely different side. And I'd like to just let people know, I went to the Rare Disease Summit on February 29th. I did some networking there, and I actually intend to go to the state legislature and request that they sponsor some sort of a bill that requires insurance companies, when they're dealing with a rare disease, to absolutely ensure that they have a rare disease expert reviewing the request. So, because what's happening is we're getting a box check saying it's investigational. And what's investigational in a rare disease where there's a treatment? It's aggravating that we have treatments that work and we can't get to them. As opposed to, I know there are a number of patients with other rare diseases where we don't even know what the treatment is, and that's a completely different situation. So if people have ideas or suggestions, or if somebody thinks that's a bad idea, I want to hear about it, because what I don't want to do is go and do something that actually ruins it for other patients either, right? I'm the most optimistic and the most perseverant person you'll ever meet. We're going to get it covered.
Yes.
And I call this friggin' insurance company every day, and I've told them I'm not going away, and we're going to an external appeal now, and I'm going to make very sure that they have every piece of evidence I have. So I don't want to monopolize it, but I do want to know if other people have experience with getting coverage for treatment, we'd appreciate sharing that.
Yeah.
And if the more I learn, the more I'll share back. But thank you.
Wow. Not all heroes wear capes. And we should talk offline. We're doing a lot of work in this space. Michael here, I'm sure, has ideas for you already. But to your daughter, what a lucky gal. You have a dad who advocates so hard for you. And that certainly makes these very challenging circumstances easier. So thank you for sharing that and for your commitment to helping her, but also all these other patients who probably also face similar challenges but don't have the knowledge or the wherewithal to navigate it as you have. So thank you for doing this service for us. That concludes our first session. Thank you to all of these wonderful doctors and researchers for their time, their energy, their expertise. I'm sure you have more fun plans you could be doing on a Saturday, but the fact that you're here with us speaks volumes. So we're going to take a very quick group picture.